Okay, everyone, we're back. Briefly about the Romberg sign. The idea with the Romberg sign is a patient that is experiencing lack of balance that is worse with the eyes closed. That's basically the main idea. The reason for that is because the sensory system is not working well, medial lemniscal system specifically, and that's why the imbalance. Close your eyes, you have no vision, so nothing to compensate. More imbalance. Open your eyes, less imbalance. So that's essentially what stands at the very foundation and basis of the Romberg sign. Okay? I'm gonna go over that again when I talk about the cerebellum because I'm gonna want to differentiate between the Romberg sign and any cerebellar deficit. Okay, syringomelia, not really related to any lesion specifically to any nerves. It simply means a cavitation over here in the central canal. The central canal over here has cerebrospinal fluid flowing throughout the spinal cord, and for whatever reason, get it might start being becoming larger and larger, and this will become a cavity full of cerebrospinal fluid. And if it's too big, it's going to put a lot of pressure on anything surrounding it within the spinal cord. So initially, we'll see bilateral loss of pain and temperature sensation, and later on some motor neurons, so motor deficits, flaccid paralysis because it's the actual nerves that lower motor neurons found over here. So simply put, the larger this becomes, the more symptoms we're going to be seeing. The more symptoms we're going to be seeing in the patients. There's a question about incontinence for the bladder, and you saw that word. Um, Okay, so there's a question about incontinence bladder. So simply think about a spastic bladder or an atonic bladder. Spastic, too contracted, atonic, not contracted. Too contracted means that the parasympathetic system is working too much, so the sympathetic system is not inhibiting it. Atonic bladder means it's really not contracting, which means that the person cannot start urination properly, and that's the parasympathetic system that is not working well. Syringomelia. Why do we see the symptoms? This cavitation over here, it becomes larger and larger, putting a lot of pressure on all the areas over here, all the nerves that are found around here. So this tiny little canal, it should be super tiny. If it's larger, it's going to put a lot of pressure on these regions, and then they're going to be deficient, right? Because you put a lot of pressure on a neuron, it's not going to be firing properly as it should. So if it expands and becomes larger and larger, it can get all the way anteriorly over here to this motor region, and then we're going to be seeing motor deficits. Initially, we'll see pain and temperature deficits because the spinothalamic tract is found slightly more posteriorly. The very motor aspect is specifically the more anterior region. So syringomelia still. So if it's only here, spinothalamic, if it's anterior as well motor, what if it's so large that it's going to affect the lateral horn as well? So up until now, we talked about the ventral horn, the dorsal horn. This is motor, this is sensory. And then the lateral horn over here, that is going to be the autonomic fibers. So having to do with the autonomic nervous system. If this cavitation is so large that it affects the autonomic system as well, what we will see is Horner syndrome. And I'll go over this one multiple times during the lectures today. It's a lesion that affects specifically the hypothalamic fibers, and that will innervate sympathetic neurons, so autonomic system. And we see three symptoms that give it away immediately: meiosis, ptosis, and anhidrosis. Meiosis means the pupils are constricted, and if they're too constricted and they do not dilate, dilation is by sympathetic system. If they don't do that, it's a sympathetic system that is affected. Droopiness of the eyelids, eyelids half closed. That's because sympathetic system usually keeps them open completely throughout the day. It's not doing that, so they're half closed. Anhidrosis, lack of sweating in the face, usually only half of the face, because it's more likely that the lesion is only on one side, and that's the sympathetic system as well. Tabes dorsalis, I actually already went over this. Remember Romberg sign? That's exactly what it is. Tabes dorsalis, usually due to neurosyphilis, or anything of that sort, or complications of that. Bilateral degeneration of the dorsal roots. Okay, over here, what are the dorsal roots? Those are the places where sensory information is coming into the spinal cord up to the cortex about touch, vibration, proprioception. If that is not, if that is lesioned, what we see is the Romberg sign. So the person is going to be unstable, and more imbalanced with their eyes closed. And there it is. Another thing we see with tabes dorsalis is abnormal pupillary responses. It's called Argyll-Robertson. So I'm going to talk about pupil constrictions later when I talk about the visual system and the brainstem. But right for now, I'm going to tell you that people with tabes dorsalis show something very weird. The pupils constrict in one scenario, but not the other. So under light or close objects, those are going to differ. And that really shouldn't be the case. The pupil should either constrict or not. The fact that we see them constricting under some circumstances, but not others, and the mechanism is not known for that, that means that something with the sensory system is deficient as a whole, as opposed to just the nerve being deficient. Subacute combined degeneration, usually due to vitamin B12 deficiency. So again, it's the dorsal columns, but this time it's also lateral corticospinal tract. So we're going to be seeing bilateral spastic paresis because of the lateral corticospinal tract. Some of the corticospinal tract are found over here laterally. Most of them are anteriorly, but some are laterally. So for this one specifically, we'll see spastic paresis, bilateral alteration of touch, vibration, proprioception. Why? Because those are in the dorsal columns, and both of these are going to be below the lesion site, just like we saw in that person in the picture. And then we have hemisection or Brown-Séquard syndrome. Imagine half of the spinal cord being lesioned, the entire half, as opposed to something that is very dorsal or ventral, or an artery that supplies blood somewhere is just a complete half of the spinal cord. And if that sounds familiar, it is because that is exactly what we talked about in this person. Half of the spinal cord at T10, specifically for this person over here, is lesioned. Anything under the lesion is going to be motor and medial lemniscal ipsilateral symptoms, spinothalamic contralateral symptoms, and at the level of the lesion, everything is ipsilateral, simply because the neurons are entering or exiting at that level specifically. That's exactly what I said before. This is from your book. It summarizes everything. Okay. Now what I want to do, we're actually not done with the spinal cord at all. We're going to talk a little bit about cranial nerves and the brainstem as a whole. That's where they come out of and go into. And once we finish cranial nerves and brainstem, we'll go back to the spinal cord and put everything together and talk about deficits to the brainstem, to certain cranial nerves, and how do those symptoms can tell you if there's actually something affecting things in the spinal cord or just more peripherally. Okay, so for example, I'll let you know that usually when we see symptoms that have to do with cranial nerves, some symptoms related to the spinal tract exist as well. And if that is the case, I know the lesion is in the brainstem itself, because in the brainstem we have all the pathways going between the cortex and the spinal cord and vice versa, and also the nuclei of the cranial nerves. So if it's a lesion in the brainstem, we'll see cranial nerve deficits and spinal cord deficits. What if we see only cranial nerve deficits? That means that the lesion is outside of the spinal cord or the brainstem, so only for peripheral nervous system.